today to give us an update from the Tennessee perspective a little bit, a Tennessee perspective on the use of services in people with IDD, and how we can interface with your system more effectively. And so thank you so much for being here today.
No problem. I'm very happy to be here. So is there a way that I can share my screen? I have a PowerPoint I was gonna.
Yes, you can share. I think I need to stop sharing for you to be able to do that. Maybe not, but in any case, before you launch into your presentation, though, maybe just tell us a little bit about yourself. Anything about your history, background in doing this type of work, and how you got over to Skyline and so forth. Tell us a little bit about yourself.
Well, fun fact is I have a bit of a problem, we can say, with education, in that I've probably spent the majority of my adult life in college. I'm actually just re-enrolled in an MBA program, which will be my second master's degree. So that's a fun fact about myself. I originally started in the behavioral health field when I was very young. Both my parents worked, I lived in the state of Kentucky, and they both worked for a mental health agency up there. And so I started volunteering very young and working with the population in a day program for adults. And when I went to college, I just kind of fell into mental health arena. Started working at youth villages as my first grown-up job, working with adolescents. Spent about 9 years there. Had a private practice, worked with individuals on the autism spectrum and the IDD population, doing ABA services for a little while in Kentucky. I actually met my husband and was going to be moving to Nashville, and one of my friends worked for the behavioral health call center and said I should apply. So I did, and I worked there for about 3 years and just accidentally applied for this position I'm currently in as a growth opportunity and landed at Skyline. So it's my first, this is my first position working directly with a hospital facility. Most of my other careers was in community mental health, so I kind of have background in both now, learning a little bit more as I go, as always. But that's basically how I got here.
So it's a family tradition working in mental health then.
Correct.
And now you're augmenting your mental health credentials with a master's in business administration.
Yeah, I leaned more toward the psychology because I don't like the math. So I'm not excited about doing those classes. But I think it's a good fit to, it's a new challenge for me, and I really like to be challenged. So I'm always looking for more education, whether it be higher education or just trainings in general. So.
Well, I'm so happy you're here with us today, and thanks to my co-host Trey King today for inviting you to participate. And so with that, I'll turn it over to you and let you present to us what you have today. And I'll probably rudely interrupt, or I'll try to not rudely interrupt, but I'll interrupt periodically, just ask you questions. And I want to invite our audience to do the same, to either post some questions in the chat box or request permission to be unmuted so you can ask the question directly. So with that, I'll turn it over to you, Emily.
Yes, please do interrupt at any time. Anytime. Am I sharing appropriately, or is it still just showing?
I see your presentation up there. So if you want to make it full screen, just say from beginning up there, and I think you'll be ready to roll.
I have two screens, so I'm afraid it's sharing on the other screen. So let me.
Yeah, you can just switch the display at the top on the notes side.
Technology, you know.
Yeah, it can really sneak up and bite you.
Where did you say to change?
What you're ready to do right now, I hate to have to do, which is make something work in front of other people.
Right.
Yeah, so
Um,
if you start the slideshow from the beginning first, and it'll show up on your two screens, and I'll let you know if the notes screen is showing or not.
So do you see the whole PowerPoint, or is it slide by slide?
Right now, we're still seeing the whole thing. It doesn't look like it's starting your slideshow for some reason.
Yeah, it's over on my other screen.
You can stop sharing and share that whole screen if you prefer.
Let me try this. I'm so sorry, you guys. I
You're
was
okay.
convinced I was going to have this wonderfully set up and not have these. Let's try it this way. All right.
This will not be the first time we've experienced any technical problems on here, so we're
There you
accustomed.
go.
There we go. Clap
All
hands for
right.
everybody. Okay, just to get started, so Skyline Madison is in Nashville, Tennessee. I know we have a wide variety of folks on the call, so at any time, if you want to stop me and ask a question, please do. I just want to make sure I give you guys the information that you need or that you're wanting. So this is Skyline Madison campus. Skyline is a two-facility hospital. We have a medical center on Dickerson Pike, and then we have Skyline Madison off of Neely's Bend Road, which is about 7 miles from the medical center. And so we offer an array of behavioral health services from adolescents 13 to seniors. We provide it in a multiple different settings. We do individual, just to basically meet all patient needs. So we have inpatient care, which is inpatient hospitalization, short-term acute care, usually anywhere from, depending on the unit, 3 to 14 days. We have a partial hospitalization and outpatient. And then all of our staff, we have board certified psychiatrists, nurse practitioners, master prepared therapists, registered nurses. We have recreational therapists. So that kind of makes up a little bit of our staff here at the Madison campus.
Was I understanding all correctly, Emily, that you are the supervisor for all of the, or the director for all of the clinical services?
Correct. I am currently the director of all things that are non-nursing. So we have a director of nursing here at Madison, and she kind of goes, oversees all of the nursing staff, but all of the non-nursing clinical staff are under me.
I got you.
And so just to give you a little bit of information, so we do provide support to Skyline Medical Center, both in the ER and inpatient. Our outpatient services, like I had mentioned before, are partial hospitalization and intensive outpatient. And I'll get into a little bit more details of what those are, just to kind of give everyone an idea of what those services look like. And then, of course, our inpatient, which is short-term acute psychiatric stabilization. So at the medical center, because to refer back to the SMARTicle, I think is what it was called. We do have a large population of of individuals seeking mental health treatment in our ER. And most recently, we realized that we just didn't have a framework to accommodate as quickly as we wanted to the psychiatric care for those individuals. And so we've redeployed our intake department into the ER. Of course, the pandemic had some effect on that as well, in that most patients coming into an inpatient psychiatric facility had to have COVID testing. And we don't have that on site, so they were routed through the emergency room to get that done. And so we didn't want folks sitting in the ERs for long length of stay and time frames waiting on psychiatric care. So we have a 24-hour intake team that works in our ER who are master's prepared, licensed therapists, social workers, or board certified psych nurses. So they are implemented immediately as soon as a patient is identified as needing behavioral health. They're deployed to that patient. And what they do, the ER staff will request that behavioral health consults. And so they'll go out to meet the patient and they'll do a behavioral health assessment, which basically entails gathering as much information about the patient as they can. What's going on currently? What are the issues that they're needing addressed? Are they have medical issues on top of that? They decide from collaterals, whatever. They get as much information as they can. They just do a basic history and then a provisional diagnosis of what that patient might need medically by the medical staff, and then psychiatrically by my nurse practitioners or licensed therapists, social workers. From there, they come back and consult with the doctor and the nursing staff and say, okay, does this patient need medical treatment first to stabilize medically and then psychiatric, or is it all psychiatric at the moment? From there, my team will refer to resources. So if the patient needs psychiatric care, they're going to determine what level they need. If they need outpatient services, do they need inpatient services? And then they'll make that referral to get those services, whether it be with Skyline, with TriStar, or with any other facility out there based on where the patient lives. Because what we see sometimes is that the patients coming into our ER are not actually local patients. They may be from another area. They may need services in another area. So we refer back out to those services. And as long as they're in our ER, my team follows them. So they will see them and round on them once a shift. They also have psychiatric nurse practitioners we pull in for medication management, because our goal is if a patient comes in and they're not on their medication for some reason, or they haven't been compliant with medication, is to get them started on their home medications or what they were taking prior to coming in as quickly as possible, in hopes that we can stabilize them and send them to the least level of care and avoid that inpatient psychiatric treatment if that's appropriate. If it isn't appropriate and they do need that inpatient, then we continue to follow them with the nurse practitioner once a day, and then my staff once a shift, until we find psychiatric placement inpatient for them.
So, Emily, just let me ask a quick clarifying question. At this level of identifying the behavioral health patient, so that could come from if I'm understanding correctly, it could come from anywhere in your hospital, not just the emergency department, for your consultation.
Correct. If they're if we have a patient that's been inpatient for a medical reason, and then all of a sudden they're identified as a behavioral health patient, and that doesn't necessarily just mean from the physician, it could be from the nursing staff, anybody that's coming in contact with that patient, and they see a behavioral health need, or they even think it, they just put in that consult, and my team will go and assess them and determine, is this something that is behavioral health, or is it something else? Because what we don't want to do is try to seek behavioral health services for patients who might not actually need it. I think overall in the state of Tennessee, we do have a tendency to place people on certificates of needs fairly quickly. And that's something we've been working on within our hospital to determine not every patient who has mental health or substance use needs need inpatient stabilization. There's an array of services out there that might help them that isn't necessarily, putting them into the hospital. So that's what my team's trying to do, is to connect those people, regardless of emergency room or inpatient, to the correct service level.
And Emily, just a quick comment here, or I want to get you to comment on. I think there was a time where we thought every time a person experiences sort of a mental health crisis, that hospitalization was the answer to that. And it seems like more frequently we're questioning that need in every case. that a person who experiences that sort of a crisis must go into a hospital to have that resolved. That there are other methods for resolving those types of crises. Do you find that to be true?
I do. And I think one of the things that we're trying to stress with our staff is that um, in nursing, what we found is that no matter where you go, you might encounter a behavioral health patient. However, you might not have the training and expertise to know exactly what to do with that patient. And so we're trying to provide that through my staff, in that education and understanding of what, a suicidal patient means, and what is baseline for each patient and their needs, and what actually does inpatient acute care look like, and why does someone need it versus someone else being okay to go to outpatient. And it's scary because everybody wants to make sure that the patient's taken care of and that the outcomes are at the most positive for the patient. And so we don't want to send somebody home and not give them the care that they need. But we also need to understand that sometimes that care can be received in the community. So that kind of reviews the context of our medical center, and how we are providing support there. We do see quite a few individuals come in to our ERs with intellectual IDD population or just regular mental health. We have partnered with TN Start program, and we've started to pull those folks in partnership with the Behavioral Health Call Center, to make sure we're getting those wraparound care for those individuals who have a team and care providers outside of the ER, to make sure that we are appropriately getting them the level of care and not just, turning to that inpatient setting if it's not needed. So that's exciting. I think it's been a few months that we've been doing that, and I think we've seen some really good outcomes and experiences for our patients.
Oh, that's great to hear.
So moving on to our inpatient, should a patient need inpatient, we have 121 beds at our hospital. Currently, 107 of those are operational. And our hospital is unique in that we kind of place populations in the same unit. So we have the highest acuity unit, so patients who have severe psychosis, schizophrenia, homicidal ideations, some aggressiveness because of psychosis or something like that. We have 29 beds on our acute B unit, and all of those patients are together. So we don't have somebody who maybe has a mood and stress type of diagnosis in the same unit as someone who has severe schizophrenia. It's similar populations. So we have that acute B unit. It's our highest acuity unit. And then we have an acute A unit, which is kind of a mixture of lower psychosis, some severe depression, stress management. And then we have 19 beds on that unit. We also have, which I'll get into a little bit later, our adult populations that are able attend a treatment mall, which is one of our models of treatment. And I'll explain that a little bit later in our presentation.
So it appears that you have, if I'm looking at the number of beds that you have on each of those, in each of those categories, 29 versus 19, you're accustomed to getting more referrals for of the highest acuity in need of hospitalization.
Correct. What we typically see here at Madison is our acute B unit stays the fullest. We frequently do not have beds available on that unit because we have patients in them pretty frequently. So we do see quite a bit increase in that population as far as that being our need currently.
Right.
We do have a mood and stress unit, which is our lowest acuity unit, mostly depression, anxiety, some suicidal ideations, but mostly just those mood disorders of folks who don't have more complex care needs. They have a little bit of just mood stabilization issues. We have a 16-bed geriatric unit. We do memory care and dementia. We do have some minimal medical interventions because we are not a full medical hospital and equipped for full medical concerns. You know, we have some criteria that, depending on the age and the need of the patient, medical concerns may or may not be able to supply their need for that. And then we get to do adolescents, 13 to 18, and that is just anybody who's 13 to 18. We treat all of the diagnosis that come to that present in the adolescent population.
Hey, Emily,
I
we
like
had
the
a
way you-
question in chat to ask if you're able to support individuals on the autism spectrum who are in crisis.
So we have, we're redefining our criteria here at Madison. One of the key criteria to be able to come to Madison inpatient is that our patients have to be at a cognitive functioning level to be able to attend our group milieu services. We have 7 groups daily on the unit, and that's in a group setting. So as long as the patient's able to function in that setting, it's definitely a referral that we would be able to look at and see if we can meet the patient's needs. It just really depends on a case-by-case basis on the functioning level. We don't want to exclude anyone just because of a diagnosis. We want to make sure that their functioning level meets what we can give them. Does that answer
Yeah.
the question?
Yeah, I think it does. You're saying that you don't rule people out based on their autism spectrum disorder. And going back to, on the previous slide, it was the lower intensity unit that you had. How does that differ from the mood and stress unit in particular? I guess because you're still treating people with could acute A be somewhat just a sort of a lesser version of acute B? Is that basically what it is?
You're exactly right. You're exactly right. Completely right. That acute A is just a little lower acuity than B. And sometimes we have some, psychosis mixed in with depression and suicidal ideations and things like that, but they're not at that severe level in which they would need to go to be. And one of the things that we also try to do is, as people's acuity start to change, we try to match them and move them down if possible into a different unit, because we are continuing those group activities in the milieu. That's the main treatment that we have. So we attempt to try to get them in with that same population, so that way they're continuing to get the level of services they need.
One other point of clarification, Emily, on the adolescent beds. I assume that pretty much if you're an adolescent, you've got to be served on that unit, though, sort of regardless of the acuity level.
That's correct. All of our adolescent beds are private rooms, which is a huge selling point. I think sometimes being able to treat, 21 patients that might have a wide variety of issues going on. We also have kind of an A side and a B side to our larger units, and so we can kind of put the patients together on the units. Like if we have someone who's a little higher acuity, or multiple patients that are higher acuity, we try to put them together. We also can separate our groups, especially on the adolescent units, to have like 10 patients on one side and 11 on the other, and run different milieu groups at those times. So that way their level of care is kind of meeting the population. We do a little bit more individual work too on the adolescent unit than we do on some of the other units, because they are so diverse on that unit with what we're could be dealing with depending on the patient. So any questions about inpatient?
I think the question that we got about autism spectrum disorder is probably asking, is there a specialized program for people with ASD, or is that a specialty population that you are reaching out to serve? And that doesn't seem to be the case. I mean, you're still reacting to what, the presentation a person has within the ER, determining if they might be appropriate for your units and making the decision from there, not based on in advance a diagnosis of autism spectrum disorder or any other diagnosis.
That's correct. We don't have a specialty track for, autism spectrum disorder. Unfortunately, that's something I think is probably a need, just in general across the state. I know that's few and far between, but currently right now we don't have like a specific program. If they're, regardless of anyone's diagnosis, if they meet the level of need and we're able to give them the services based on which unit, that's basically how our criteria. I mean, we do have some exclusionary criteria depending on the functionality of the patient, medical conditions, things like that, but we really try to exclude in instead of out. We want to try to make sure that we're able to provide the services the patient needs, and if we can, then we want to place them on our unit, and if we can't, then, if they're in our ER, we continue to find the place that does meet that service or that need, what services meet that need.
That's great. Thank you for that.
You're welcome. So here's a little bit of information on our treatment mall. So all adult units, acute A, mood and stress, and even B, depending on their abilities at the time to attend, will attend a treatment mall. And basically what the treatment mall is, it's a concept where patients can go and actually choose different groups to be in. Regardless of what unit they're on, they get 7 groups a day. And what those groups kind of look like is we typically have a morning group that just kind of talks about what our goals are for the day, what our day is going to look like. We have unit therapists who do processing groups, adjunctive therapists, which are our recreational art, music therapists. We have relaxation groups. We have nursing groups. We even have pulled in some of our staff around the hospital that some folks, other facilities might not be able to use, but our dietitians, they do groups, our pharmacists do groups, our case managers come in and do wellness groups and understanding discharges and follow-up care and resources. So those are the types of groups that we have throughout the day. In the treatment mall, it's from 10 a.m. until 2 p.m. and all of the adult units that are able go to that. They're able to specifically target more diagnosis specific or need specific classes. So we have multiple groups running at a time. The patients are able to decide which groups they want, have a little bit of choices in what they would like to learn or gather more information on or participate in. Right now, because of COVID, we're running kind of a modified model of our treatment mall in that we're trying to be able to contact trace anybody, within the milieu of who might, if we have a positive, who might have been in contact with that person. But we try to give them as much opportunity to choose those classes. We also kind of have a track, so our physicians and our staff who are doing the treatment will also help guide the patient into what might meet their need. But ultimately, we try to give them as many choices as possible. And the way that we do that is within the first 24 to 72 hours, our patients go through quite a bit of assessments. Sometimes they get tired of talking to us, I think, but we have a psychiatric evaluation. They have a medical evaluation. They have an adjunctive therapy assessment, which just comes in and talks to them about what things, recreationally, art, music, what things do they like. And then we also have a psychosocial assessment that gives us kind of a background on why they're here, what their current information is. And then we also have a treatment team meeting 3 times a week in which our physician and all of our clinical team get together and discuss what treatment along with the patient treatment goals that they have while they're here. And so that's how we kind of determine what classes we try to guide our patients through in the treatment mall. The adolescent unit and the geriatric unit do not participate in the treatment mall. They have program specific groups based on their unit and their population, to which we kind of alter depending on the population at the time. If we have a lot of higher functioning people on our geriatric unit who are not, dealing with dementia or anything like that, then we tailor our groups to those folks. Same with adolescent. If we have a lot of adolescents on the unit at the time that have suicidal ideation or some similar diagnosis or issue, we try to tailor our groups to address what's current in the milieu. Any questions about the treatment mall?
I think we've got a question that we might be able to hold till the end, so I will, we'll wait on that one for a little bit.
Okay. So the next fun part of the services we offer is we have outpatient services. And so our outpatient services are able to kind of address individuals who have anxiety, some borderline disorder, bipolar disorder, trauma, depression. We have substance use, stress management. Again, the same as inpatient, we have board certified psychiatrists, nurse practitioners, licensed drug and alcohol counselors, master prepared therapists, case managers, and we also have adjunctive therapy and recreational therapy with our outpatient as well. And so there's two different types of outpatient. We have intensive outpatient program, and then we have our mental health partial hospitalization. So our intensive outpatient program is kind of the lowest level of care. Individuals who are in the community, they maybe just need a little bit more than just that individual weekly or biweekly counseling services. We have that program. It's 4 to 6 weeks depending, and it runs Monday through Thursday at 9 a.m. until noon. All of our partial programs also, I'm sorry. Did I hear somebody with a question?
I don't think so.
Okay.
I'm not sure.
So the fun part about our outpatient is we have multiple different tracks. We have the mental health partial hospitalization, and this is mainly for individuals with just emotional difficulties. They might be stepping down from inpatient, or they're not quite at the level of inpatient, but they need a little bit more than just intensive outpatient. It's usually 3 to 4 weeks. It's from 9 a.m. to 2:45. We do serve lunch with that. Our other track for partial hospitalization is we do have a trauma track for partial hospitalization, PTSD of any sort. We do have quite a few folks that come in with military backgrounds into this track. It's also the same time, 9 a.m. to 3-ish, 2:45. It's also about 3 to 4 weeks. And then we have co-occurring, which is, substance use and mental health. All of those programs also have medication management provided in the partial hospitalization, which is helpful to those individuals who need just a little bit more intensive treatment. So how do you get to us? As we talked about, a lot of patients come into the ER, but that's not the only way to be referred to services. If you're a provider or a therapist or somebody in the community or even in a hospital, the great thing about TriStar is that we have one hub that does all of our referrals. But keep in mind when you're going to make a referral, whether it be to inpatient, outpatient, anything like that, there's a few things that you want to make sure that you have when you give us a call. And these are some of the things that are important that will help us when we're taking your referral. Patient name, date of birth, address, payer source. In the state of Tennessee, any patient who has TennCare, if they're going to be inpatient, they have to be seen by mobile crisis. they're the gatekeepers to approving that inpatient stay. It's just the process. And so we want to make sure that that happens, especially if we're going inpatient. So knowing that if they're TennCare patients, patients who have TennCare, we can make sure that that mobile crisis assessment's been done. It's very important if we have any DPOAs, which is durable power of attorneys for healthcare. We get a copy of those. Any psychiatric symptoms of why they're needing the care, any diagnosis, medical history, physical limitations for outpatient. All of the outpatients patients have to be able to do their own ADLs. They have to be able to, walk and move around and take care of all of that. And then any intellectual limitations or diagnosis is helpful to know. So that way we can determine not just the diagnosis, but their functioning level is the most important piece of that, to know if our milieu services is actually going to benefit that patient or not. And to make a referral.
Oh, let me jump in just for a second here, Emily. So one thing about the DPOA, a lot of the folks served within our system have a conservator, which is a little bit different legal instrument, but it probably functions similarly to what you have identified as the DPOA there. So in other words, it's a legal decision maker for the person, and that's what you're interested in knowing about, right?
That's correct. And that way we can make sure all parties who are needing to be informed are informed on those treatment decisions. Once they get to us, making sure the paperwork's signed and releases are signed and that we're keeping them in the loop. The quicker that we have that, the better informed we can keep those individuals.
Yeah. The other thing I was going to bring up is that I'm really glad you brought up that about the different levels of intellectual ability, because 87% of people with intellectual disability, a diagnosis of intellectual disability, have mild intellectual disability and probably would be able to participate in a lot of the activities that people are doing. And so I think it's terribly important to find out the level of intellectual limitation in those circumstances, rather than responding to intellectual disabilities with a broad brush. So I'm so glad that you brought that up.
And that's the most important part, especially in determining not only the level of care, but just making sure we're matching their functioning level, and making sure that we can give them the treatment that they need. So making a referral, the Behavioral Health Call Center is kind of the hub of not just Skyline, but TriStar Behavioral Health. This is the number you can call. They're available 24/7, 7 days a week. And basically they can help you if you think that your patient or a loved one or whoever needs any type of mental health treatment or substance abuse treatment. They can help you get outpatient appointments set up. They can take an inpatient referral. They can kind of help you navigate, if you're in the community versus in an emergency room, or, they're the hub to give you all of that information and getting you contacted or connected to the person to give you the services that you need.
Okay, great. Thank you so much for that. So we've got a couple questions in the chat box. Michelle, you want to facilitate these questions?
Sure. I think that one was just the follow-up question in terms of what options are available to those patients who do not meet your eligibility requirements. For example, if the functioning level, based on functioning level.
So if the way that the Behavioral Health Call Center works, if a patient is in any of our TriStar ERs, or we'll just say hospitals, in a TriStar hospital or an affiliate hospital, the Behavioral Health Call Center will make sure that if we are not able to meet the functioning level or the need of the patient based on their functioning level, they will make referrals to appropriate inpatient facilities. As far as outpatient facilities, if you're in our Skyline ER and we're not able to meet that level, then we're going to get you in touch with a resource that can. We have, that's what our social work and nurse practitioner, board certified psych nurses do, is that if you're not needing inpatient treatment, we're going to find a resource, or we're going to contact Trey and find a resource, or the behavioral call center. We have a long list of places. We also get in touch with the insurance provider and see if there's a case manager that can help us. Look, we're not going to just leave the patient with no services. We're going to try to connect them with whatever service level they need, whether we can provide it or we need to find it from somewhere else. But if you're in an ER or inpatient hospital within TriStar and you need inpatient psychiatric treatment, they will follow that patient until they get the treatment they need. They will refer to all of HCA TriStar. They will refer to all other facilities, inpatient facilities. We've gone as far as trying to refer patients out of state to other facilities. We sent someone to Oklahoma not so long ago to a TBI specialty unit to help with the traumatic brain injury and some services that that patient needed. I mean, we have a good team of case managers and people at the call center who have expertise on where we can send patients and referrals that we can make. So we really try to do that regardless of whether it's with us or someone else.
Yeah,
And
and Trey has been involved with you guys in helping guide you a little bit of this. Trey, do you want to comment on this?
I was just going to say that TriStar and HCA, Emily and Meredith and the call center, they have been an excellent partner. They have gone so far. We have a partnership agreement with all the TriStar facilities with 10 Start. There's a lot of collaboration amongst the different agencies. So they truly have stepped up to the plate, where a lot of the other hospitals that we've not had the ability to get into that level of agreement yet. But I mean, TriStar has really stepped up. So, I am very appreciative of their willingness to be creative and find ways to admit some of our folks that are needed, look for other options to help kind of, collaborate with us and find what's in the best interest of the patient. So, I mean, it really has been wonderful. Even when it may not meet the milieu of the unit, their assistance and willingness to find the appropriate treatment hasn't ended. So I think, a huge congratulations goes to TriStar HCA, Skyline, Emily, and all of them for their help.
Yeah, I'll echo that too, just on 10 Start's behalf. The partnership and collaboration and willingness to just listen to our suggestions on what we think might be going on with a person in crisis has been great. And Meredith especially, I always call her out, but she is kind of our go-to when we've got somebody involved with one of the TriStar HCA hospitals. So she's been amazing as well. But yeah, I mean, we've really enjoyed the partnership. We've definitely learned some things and made necessary adjustments, but it's been overall very helpful to have those connections.
I think we've been
Yeah,
able to do a better job at getting those wraparound services for the patients rather than just kind of tunnel vision into it has to be this one treatment. We're able to look at the individual and say, okay, this individual needs these things instead of, the other way of thinking.
Yeah, Emily, do you find that your staff have enough training on how to work with people with IDD, such that it would, open up more possibilities with respect to the types of services that they might qualify for, or or to be referred to? Do you find that those resources are plentiful, or do we need more there?
I would find that I feel like my staff are trained fairly well on how to work with that population. I do think our resources are lacking for this in particular population. I think it's difficult at times to find the correct placement for them, in that there's not a lot out there, and our populations sometimes move frequently, and once you've been to multiple places, then it's kind of hard to find somewhere else when you've ran through some of them. I think that that's probably the biggest need would be more resources, group homes, and respite even for families who have patients that are not in group homes. Like, having all of those resources at their fingertips is definitely a need, I would say.
Yeah, huge need that's out there. Of course, sometimes the need is to have the services that facilitate remaining in the community, remaining at home, remaining in a setting such that, if it can be made safe and that you can address the concerns that are out there. And that's a large part of what our assessment and stabilization teams, Tim started our assessment and stabilization teams are doing. We also, but the missing piece is in those circumstances where we really need it. For a lot of people in our population, there's still, not a place for people to go for inpatient. And so that's certainly a need that our 10-star assessment and stabilization teams are working on, and our department is working on as well. So I appreciate so much you coming and talking to us about all of this today. You've been a wonderful presenter and a wonderful partner, as Trey pointed out, in everything that we've been doing. We appreciate you so much.
Well, I appreciate you guys having me, and hopefully we can continue that partnership and do what we need to do for our patients. I did want to clarify, it looks like somebody had a question about what would precipitate a patient from moving to a different city if they can participate in our groups. That would be, there shouldn't be, if we have availability, capacity to take a patient inpatient or outpatient, and they live in the Nashville area, they shouldn't be referred to another area. What I was talking about previously is with TriStar being a tertiary service line, or not TriStar, but Skyline, we have a lot of people who are flown in from different areas. We have a burn unit and trauma unit and things of that nature. And so sometimes we get a lot of folks who aren't from the Nashville area. And so we don't stop looking for services just because they're not from here. We connect them to services in their area when they go back home. So that's what I was trying to clarify with that.
Yeah, that's great. Was there any other questions I missed, Michelle?
Well, we did have a request to put the 24/7 behavioral health referral phone number in the chat, but Trey took care of that for us. And then one comment was just that respite is a huge need for families who have someone with autism in the family. So, but that was it. I kind of felt like Emily, you had covered that. You covered that question in one of your responses already. It was the only reason I didn't circle back to it.
Oh, no problem. And I put my my cell phone number, my work cell phone number up in the chat too. Should you have questions about referrals, services, anything with Skyline that I can help with, please feel free to reach out to me. I'd be more than happy to talk to anybody individually about scenarios or situations that they have questions about.
And she answers the phone. I will say that. There's not many that give out a number and actually answer the phone. I can vouch that Emily does. So.
Well, that's great. And so again, Emily, thank you so much for joining us today. Everybody, this is the Clinical Consultation Network. As you know, we do this every Tuesday at 12:30. So if you tune in again next week, we'll have another fascinating guest for you. I appreciate you all being here, and we will see you again next week.
Thanks, Emily.